Hello, everyone. This is Dave Iverson. I'm the Michael J. Fox Foundation contributing editor and moderator for today's Third Thursday webinar. As many of you know, you can log in every third Thursday of the month at 12 Eastern, 11 Central, 10 Mountain, and 9 Pacific to hear a conversation about topics of importance to all of us in the Parkinson's community. And so we hope you'll continue to mark your calendar and join us throughout the year as we continue these webinar sessions. Throughout the hour today, our topic, of course, is the who, what, when, and where of Parkinson's disease. And throughout our hour today, you can submit questions, which we'll start taking about halfway through our presentation today. So in about 30-35 minutes or so. There's a little Q&A box near the middle of your screen, and you can type in your questions there, and we will do our best to get to as many of those questions as we can in the second part of our session today. And then if we don't get to your question, and we likely won't get to all of them, you can always visit the Michael J. Fox Foundation Facebook page on Monday at 12 Eastern, where we'll do a live Q&A to further pursue this topic of Parkinson's disease diagnosis. One last point before we get started. The slides and resources from today's webinar are also available for download. There's a box called Resource List on your screen, and you can click on the link there, and the document will open in a new browser window, and you will be able to save and print documents from there. So let's get to today's topic. Again, our focus today is on the subject of how Parkinson's disease diagnosed. An important topic for obvious reasons. Experts say there are 1 million people in the United States and 5 million worldwide living with Parkinson's disease, but there's real questions sometimes about how many of those people actually have Parkinson's, or for that matter, how many more may have Parkinson's but don't know it. And that's the question we want to explore today, the challenges of contending with Parkinson's disease and how we go about diagnosing that. Here are some of the questions we're going to cover. How is Parkinson's sometimes misdiagnosed? What are the ins and outs of diagnosing Parkinson's disease today? How is that being refined? We're going to talk some about the DAT scan, which many of you may have heard about, and its usefulness in diagnosing Parkinson's disease, but its limitations as well. Talk more about why an early and confident diagnosis is important, both for patient care, but of course also for research. And then we'll spend a lot of time talking about how we're going to work on getting a more prompt and more accurate and earlier diagnosis. Let's meet who's going to be joining us for our conversation today. Dana Jennings is with us. Dr. Jennings is the Clinical Research Director at the Institute for Neurodegenerative Disorders in New Haven, Connecticut. Dr. Jennings, thanks very much for being part of our webinar today.
Well, thanks for letting me join. This is a real honor to be able to be a part of this conversation about the diagnosis of Parkinson's disease.
We're happy to have you, and happy to have you particularly with all the interesting research that you're doing in this arena. Joining us as well is Dr. Samantha Hutton. Samantha is the Senior Associate Director of Research Programs at the Michael J. Fox Foundation and has a particular both research interest, but also in terms of the work that she's managing at the foundation, particular focus on this area of Parkinson's disease diagnosis. Samantha Hutton, thanks for joining us as well.
Thanks very much, Dave. It's a pleasure.
And we hope that Bill Bucklew will also be joining us soon. Bill is someone who was diagnosed with Parkinson's disease in 2012. Bill is a product development executive in Illinois and has an interesting story to tell about his own experience with getting diagnosed with Parkinson's disease and the way in which he has contended with that diagnosis. And we hope Bill will be able to join us shortly. Bill, are you there?
I am, Dave. Yes, I'm here, and I'm very happy to be here. So.
Okay, great. Thank you. Thank you. Wasn't sure you were aboard, so great. Glad everyone's here. And now let's dive into the meat of our conversation today. We want to take up first kind of what the challenges, some of the challenges are in Parkinson's disease, which are kind of twofold. One is this first problem with people getting diagnosed sometimes with other conditions or just not getting diagnosed properly at all. Sometimes people who have more of the kind of motor symptoms of muscle rigidity or problems in walking, that's not as delayed as promptly sometimes as people with tremor, which is perhaps a more obvious signal of Parkinson's oftentimes. And then sometimes symptoms just aren't taken in as part of Parkinson's right away because they're thought to perhaps be some other condition, perhaps something to do with aging or many other things. And Bill, let's get started with your the story of your experience, because I think it's typical in many ways. Describe a little bit of what was going on with you. You're an athlete, active runner in particular, and that's when you first started noticing something. What was going on, and tell us a little bit about the journey to diagnosis.
Sure. Yeah, that's right, Dave. I've kind of been an athlete my whole life, and I don't mean an athlete in like I'm ultra competitive and really a great athlete, but just that I do enjoy exercise and do compete at a normal level. So I had this running group in my company in 2005, and we were running 2 or 3 times a week at lunch, and I started noticing a tightening in my leg after I'd run, a half mile to a mile, that would continue, and I could stretch out a little bit, and then I'd be able to continue to run, and it would tighten again, and it was kind of a repeating cycle. And it was pretty consistent and somewhat progressive. So after maybe a year or so of kind of wondering what was going on, I went in to see an orthopedist, and I have some pathology with degenerative disc disease, L3, L4, L5, degenerative disc in my back. So the orthopedist felt at the time that it was either some form of sciatica, which is kind of the impinging of the nerves that run through the leg and the back. And I did the MRI. They looked at it. Yep, it looks like that's what it is. I went through rounds of physical therapy, core strengthening exercises. Nothing really changed it, and this went on for a number of years, right? And almost to the point where I was like self-doubt. Was it something mental that was a problem with the way I was carrying things out? I kind of, because I never really found a path to getting better and didn't have the right diagnosis, it was really, really frustrating. And I ultimately, after Googling and researching online, found an article in the New York Times where a woman had basically the same problem and was then later diagnosed with Parkinson's. So started exploring that on my own a little bit more and noticed, some triangulation between my symptoms and what are kind of more classic symptoms, handwriting difficulties, lack of coordination in one side of the body, that kind of thing. Basically self-diagnosed and said, wow, this is starting to seem like something here. Went in and then ultimately had that confirmed, but that wasn't until 2012. So, I literally went through like 6+ years of trying to find an answer to what my problem was, and it was a pretty difficult time for me and fairly frustrating.
And Dr. Jennings, let me ask you to comment on the story we just heard from Bill, because I think it's not an uncommon one, perhaps a longer period to diagnosis than is true for some people, but that sort of the way in which the symptoms of Parkinson's can sometimes read as other things. Bill had other things going on, some disc issues, a variety of other things that made this a difficult task, and in the end it almost, as Bill describes it, became a situation where through his own research he wound up sort of figuring out what it was rather than through someone in the medical community coming to that assessment earlier. So it seemed to you, Dr. Jennings, like a kind of standard story, and what can we tease out of that, I guess, that's relevant to our larger discussion today about the challenges of Parkinson's diagnosis?
Sure. So you're right. It's not that uncommon a story for someone with early symptoms to not turn up in a neurologist's office, but maybe another specialist like an orthopedist or, or other, rheumatologist is another common place people turn up. And I have to say it's interesting. I mean, Parkinson's is not that common a disorder, but it's also not that uncommon, so it's kind of in the middle. But it is interesting that unless you really have a background and understand the disease or the condition, it's difficult to pick it up, especially in the early stages. So it's not so uncommon for these medical practitioners to not, really pick up on the subtleties of an early diagnosis of Parkinson's disease. Once in a while, we'll see people that are referred to us in the early stages with a very astute clinician, who's not a neurologist, but I would say that is pretty uncommon. So it's not an uncommon story at all that the individual themselves sort of is left to do their own research and identify, that it may be a neurological condition and self-refer themselves to a neurologist or a specialist focusing on Parkinson's disease. I will say, and I agree with this, David, that the duration of the symptoms is a little bit uncommon, although I have to back that up by saying there's a lot of people that have symptoms that predate the diagnosis for years, and this may just be a situation where it's just a very slowly progressive condition, and it took several years, on the order of 7 to 10 years at least, to get the diagnosis.
It's
sort of at any rate, it can be very frustrating.
David,
Go ahead,
if you don't
Bill.
mind, I just want to add one thing that might be relevant. I think because I was exercising at a pretty intense level, and the symptom was only initially occurring after some period of intense exercise, that I may have gotten purview to the symptoms much earlier. If I wasn't exercising at that level, I wouldn't even have noticed anything myself to start.
Mm-hmm.
So, this tightness only occurred when I was running, so the symptoms kind of mainstream day to day didn't show up for another couple of years. So in some ways, I think I had an earlier indicator than some people might.
It's an interesting point, and probably points to the fact that while it took a long time, on the other hand, because you're an athlete and someone who was tuned to your body, it was something that you also wanted to make sure you got right. And as Dr. Jennings suggests, this is to me kind of the good news and bad news about Parkinson's. The good news is that it's slow progressing and sometimes takes a while to figure out what you have. The bad news is that it takes a while to figure out what you have. Let's move on if we can and talk about another dilemma in Parkinson's before we start talking about the ways in which we diagnose it now and hope we get better. As Bill's story illustrates, it's sometimes a problem just to figure it out. Another issue comes up sort of from the other point of view, which is that people who don't have Parkinson's are told that they actually do have Parkinson's. So people are diagnosed with Parkinson's who actually don't have the disease. We think about 20% of people who are diagnosed with Parkinson's actually don't have it, and there are a variety of reasons that you see on your screen here. Other conditions, Dr. Jennings, that kind of present as Parkinson's but aren't necessarily. We mentioned essential tremor, some aspects of Alzheimer's. There are other forms of Parkinsonism, such as multiple system atrophy, that can look like Parkinson's. This is a complex situation for clinicians and researchers, and you are both, Dr. Jennings, because there are these other kind of look-alike diseases, correct?
Right. So, I mean, they really come in two different categories. One is conditions that actually mimic Parkinson's disease that don't have any of the changes in the brain that would really suggest a dopamine deficit or a problem with Parkinsonism, but may just be a mimicker of Parkinson's. And those would be things like, medications that can result in symptoms that look like Parkinson's disease. And certainly it's always important to look at a list of medications when evaluating somebody because there's a number of them, as well as things like stroke or other arthritis, other conditions of that nature. And then there's the second class of the second type of confounders, which is really atypical forms of Parkinsonism. So not necessarily idiopathic Parkinson's disease, but the atypical or Parkinsonian syndromes that are such as MSA or multiple system atrophy, progressive supranuclear palsy, etc. Now these are much rarer conditions. So it's really, it's unusual for us to see these, but nonetheless, you have to have an index of suspicion always for those conditions. And I would say usually they don't present in the earliest stages with the atypical forms, but we can, more clearly diagnose those as the condition progresses.
Well, let's begin to talk some about how we diagnose Parkinson's today and how we can get better at that. On this next slide, we see this key point at the headline on this slide, which is that there's no objective diagnostic test currently for Parkinson's disease. In other words, there's no blood test or something that will definitively biologically give you a measurable objective reading that someone has this disease. It's all about and we see the picture on the screen that all of us who have a Parkinson's diagnosis know well, where you tap your fingers and you do various things that clinicians like you, Dr. Jennings, observe in order to determine that. And Dr. Jennings, that's really the way this disease has been assessed for centuries in some ways. We're, of course, better at it. We're more refined at it. But it still takes the trained eye of a clinician to make this distinction, and that that's fairly unusual, isn't it, within the disease world that it has to be based on observation versus a kind of actual test?
Yeah, I think in this day and age it is a little bit unusual to have a condition that's diagnosed entirely by a physical examination. Of course, now we're going to talk a little bit about additional testing that's become available, but there really isn't a blood test or anything that simple that can help us in terms of clarifying and being more accurate in the diagnosis of Parkinson's. So what's happened over the years is, that we've developed now some specific criteria that increase the chance and increase the accuracy that we get it right early on in the disease. And specifically, those are employed by neurologists, but also more specifically, movement disorder specialists are more aware of those criteria, but involve, the bradykinesia is a requirement for the diagnosis of Parkinson's disease. Bradykinesia is slowness of movement. And then individuals need to have at least one or more of the following symptoms: tremor, rigidity, or a problem with gait that looks to be consistent with Parkinson's disease. So those criteria do exist, and they're not 100% accurate. I will say, but they are actually pretty good. That in combination with the response to medication certainly increases the accuracy. But it is interesting that it's still a clinical diagnosis effectively.
And Bill Bucklew, when you did get to a neurologist and they made that final determination for you, I assume it was with those sorts of clinical observations that Dr. Jennings is describing and that we see pictured on the screen. Was it still, even after all of the research and sleuthing that you did, was it still a shock to you when you finally got that more definitive diagnosis?
Yeah, Dave, I mean, it's really interesting because as I had mentioned before, had done all this research and was very confident that I did have Parkinson's, but hearing that directly from the neurologist, still I kind of describe it as almost like a punch in the stomach. I can't even really describe it. It just, even knowing what I knew, it still was the finality and the absolute nature of it was still a bit of a shock. I was there with my wife, and it was still, I kind of remember just getting really kind of nervous, and yeah, it was still shocking, even given the fact that I had really had months to really contemplate it and pretty much knew what the diagnosis was going to be. So
yeah. Well, let's talk about how we can get better with all of this. And the first topic that we want to take up is the question of dopamine scanning and scanning what kind of dopamine activity is going on in the brain. Dopamine, of course, is what goes missing in Parkinson's disease. And so we're going to talk next about something called a DAT scan, which is this dopamine transporter scan that visualizes the amount of dopamine activity in the brain. You can see on the screen the difference between someone who has a normal dopamine activity level on the left and someone who appears to have Parkinson's on the right. But again, there's some limits with this too, Dr. Jennings. So why don't you describe a little bit about what a DAT scan does and what it doesn't do as well?
Right. So let me just back up for 1 second and say a couple things about the DAT scan just in general. So the main problem in Parkinson's disease is that there are cells deep inside the brain. You can see here on the picture the cells that we're talking about. The cells deep inside the brain that are aging faster than they should be. And those cells that we're talking about are actually in the substantia nigra, and they're being lost in individuals at a faster rate in individuals that have Parkinson's disease compared to individuals that are just aging normally. So the decrease in cells is actually cells of which dopamine is being produced. So these are dopamine producing cells. So that's what lowers the amount of dopamine in the brain, because we don't have as much or the density of those cells to produce the needed, the required dopamine for an individual. So you can see here on the right-hand side that there's, again, the bright area of pink and purple and yellow, basically on my screen, that's much smaller, and it's rounder on the right than it is on the left, where it is more egg-shaped or oblong-shaped. And so the decrease in that lower part of the egg shape is the loss of cells that we usually see in individuals with early Parkinson's disease. So, of course, replacing the missing dopamine with dopamine replacing medications is the treatment for this condition. So, how this actually helps us in terms of diagnosis is certainly it helps us in differentiating people that have a Parkinson or a Parkinsonian syndrome from individuals who may have an orthopedic or rheumatologic problem, or a stroke or drug-induced Parkinsonism, as I was talking about earlier. But in the case of somebody that has an atypical form of Parkinsonism, they may also have an abnormal scan. So it doesn't help us in terms of differentiating the atypical forms of Parkinsonism, but it does help us in differentiating some of the other conditions that are completely unrelated to a decrease in dopamine producing cells in the brain.
And Dr. Jennings, do you see this as something that could become more of an everyday device that you as a clinician would use in your office to make a final determination, or is it expensive enough, involved enough, and not revealing enough, finally, to not make that a kind of everyday diagnostic tool?
So I think it's not an everyday diagnostic tool for a couple reasons. I mean, I think that, there's a lot of really good clinicians that are able to differentiate Parkinson's disease from other conditions clinically, and it may not be necessary to have a scan. That definitely exists, and also if there's a good response to medication, it certainly wouldn't probably warrant a scan like this. But there are cases in which it's a little trickier, where somebody may come in and have, similar to the situation that we heard earlier, may just have rigidity in a lower extremity, and it may not be so clear. It's a much more subtle symptom. And I think where we really shine in terms of DAT scan is in the earliest stages. So when there's some subtle symptom, we're not quite sure of whether this is going to go on to result in a diagnosis of Parkinson's disease, and we may actually say, well, why don't you just come back in 6 months and we'll see where you are. We could actually know at point in time whether there's going to be a dopamine transporter deficit or a decrease in dopaminergic cells that's going to result in a diagnosis of Parkinson's.
And one other just quick scanning point I would like to make just for clarification purposes. Sometimes people say, well, what about an MRI? Or my doctor wants to have an MRI. And Bill, you mentioned having an MRI. But the way in which an MRI is helpful, and I assume this was your experience, Bill, was to rule out other things, right? I mean, it was done to see, well, is there something else going on in the brain, whether that's, in your case, a disc problem or perhaps looking for a tumor or something else. It's not that an MRI isn't going to tell you anything definitive about Parkinson's. Was that your experience, Bill? And Dr. Jennings, comment too, if you would, please. But Bill first.
Yeah. I mean, in some ways it had the opposite effect in that it led us to a misdiagnosis of this problem that the symptom was causing, because I had this degenerative disc pathology that, when mirrored with a tightness in my leg, kind of made sense from the orthopedist standpoint. And obviously I went back and forth for years, and believe me, he was thinking about this a lot, and it really it kind of had the opposite effect and sent us down a path of physical therapy and core strengthening and other things to try and address the symptom that ultimately was not the cause of the symptom. So it's pretty interesting.
And Dr. Jennings, just to underline the point, an MRI doesn't tell us anything about Parkinson's. It's used to rule out other problems, correct?
Right. So usually as part of the work, it's part of the workup. A neurologist or a general practitioner for that purpose would order a brain MRI, and in your case you ended up with a lumbar spine MRI. But a brain MRI that would actually again, if possible, rule out the possibility of like a stroke or a mass of some sort that would explain the symptoms. Generally speaking, people with Parkinson's disease have a normal MRI, and sometimes we'll see people as a first consult where they come in with their MRI and say, but the MRI is normal. That's right. In Parkinson's disease, it is normal. Doesn't show the pathology.
Okay, well, let's talk about how we can take new steps to further improve our ability to diagnose, and talk some about why this is so important. It's obviously self-evident from a care and treatment point of view to get the correct diagnosis so that someone, like in Bill's situation, can get that diagnosis and begin proper treatment. But there are a variety of other reasons why getting a proper diagnosis is so important. Both in terms of the care of patients, but also in terms of research. And we list a number of points about this. And I want to bring Dr. Samantha Hutton from the Michael J. Fox Foundation into our conversation at this point to talk about some of these, the reasons why this is so key. And I'm going to, obviously we want to be able to observe, as it says in this first bullet point, and learn about Parkinson's from people who actually have the disease. But Samantha, I'd like you to comment some on this second point, which is that one of the tricky things with Parkinson's is that we are sometimes testing new drugs in clinical trials, and it's a problem, right, if we wind up testing those drugs on people who don't have Parkinson's disease. And as we learned earlier, about 20%, we think, of people who initially get a diagnosis of Parkinson's, turns out they don't have them. So talk a little bit, if you would, Samantha Hutton, about the importance of diagnostics as it relates to research and to identifying what we hope will be treatments that will either be improvements in the symptomatic care of patients or ideally, of course, slow down disease progression.
Right, Dave. I mean, that's exactly the key point. I think Bill and Dana and yourself have done a great job in highlighting why it's important from a patient perspective, but it's also really important from a research and scientific perspective as well as a drug development perspective. Obviously, studies looking at Parkinson's disease need to employ the correct population if they're going to have any chance of success. And I think that's really important to enable researchers to grow the knowledge base of Parkinson's and cut down on any potential confusion that could clearly point us to new areas of study or drug development. But specifically, when we're testing a drug against Parkinson's disease, whether it's high levels of a protein like alpha-synuclein, which is the protein that accumulates in the brains of everybody with the disease, we really want to make sure that the people in the study have that target so that the drug that we're testing can act on that target and then do its job. So that's sort of setting up the trial with the highest level of success. So other drugs that may actually work on Parkinson's would then give a low signal of success if it wasn't sort of set up in that way. And I think this also speaks to the point of earlier diagnosis, because if we do have these potential options early on and we're looking at exactly the right patient population, that gives us the ability to intervene potentially earlier, and the potential therapies that would be disease modifying as opposed to just symptomatic would be able to slow or stop the disease in clinical trials if they could look in the test population that was most applicable and would have the most impact. So I think this is really important from a drug development perspective because it means smaller, less expensive, easier to run studies as well.
And so if we take an example like the story that Bill Buckley described of his own diagnosis, if that diagnosis could have been made at a much earlier stage, and if we were at the point, and we're not quite there yet in research, where we had a disease-modifying treatment, something that would actually slow down the progression, obviously makes a world of difference if we can begin that sort of treatment much earlier on, and that's what an earlier diagnosis would allow us to do. You mentioned, Samantha Hutton, the question of alpha-synuclein, and so let's turn to that next about a really interesting new venture that is going on in. Sorry, I jumped ahead one slide by accident. Let's talk a little bit more about the question of how that key protein, alpha-synuclein, could be used to form earlier diagnosis of Parkinson's disease. This is something that both you and Dr. Jennings are involved in. But tell us a little bit more about this idea, Samantha, about the idea of alpha-synuclein. First, in terms of what we hope we'll be able to do as far as imaging it in the brain. Right now, we know that alpha-synuclein is a problem in the brain. We know it clumps up, and we think it leads to cell death, but we can't see it. So where are we in being able to actually see and image that protein in the brain?
Sure, Dave, and the advantage of imaging alpha-synuclein as opposed to a DAT scan, for example, would be that it's very specifically a protein that we know accumulates in the brains of everybody with Parkinson's disease, and there are several disease-modifying therapies that are currently in the pipeline that specifically are targeting that protein. So if we were able to develop an imaging agent or a brain scan that could specifically light up those alpha-synuclein molecules in a person's brain, we'd be able to see how that alpha-synuclein was changing over the course of a drug treatment or over the course of disease progression. So the Fox Foundation is funding multiple groups on this effort. It's a big, big priority for us. And the results are so far looking promising, and we're hoping that if all goes well, we will be able to test one of these alpha-synuclein imaging tracers in humans sometime this year.
And in addition to that effort, Dr. Jennings, to find a way to see alpha-synuclein in the brain, one of the interesting parts of the alpha-synuclein story is that it shows up elsewhere, and these clumps show up elsewhere in the body, whether that's in skin or blood or spinal fluid, different tissue. And so there may be a way of detecting abnormal readings of alpha-synuclein in other parts of the body, which could lead again to a different way or an earlier way of diagnosing the disease. Say something about those efforts, if you would, and this so-called S4 study, the systemic synuclein sampling study, that's an effort to figure out a way that we might be able to do just that.
Sure. So, Dave, as you just mentioned, it does appear that this protein synuclein actually, there's deposits of the protein not only in the brain, but also in the peripheral tissues. And when we say the peripheral tissues, these are tissues that are, throughout the body, but actually also have some nerves within that tissue. So that's how the synuclein is formed. It's within the nerves. Fibers in the peripheral tissues. So the peripheral tissues may actually be an earlier indicator or earlier place where synuclein begins and then moves centrally. There is some hypotheses around this, but it may be that individuals have synuclein peripherally years before they have a diagnosis of Parkinson's or even, the subtle symptoms that we've heard about so far. So there's a study that's ongoing now, and this is really built on a number of studies that have been funded by the foundation over the years to try to, in a single individual with Parkinson's disease, try to characterize that synuclein pathology peripherally and understand whether we could actually develop a test or a series of tests that would be sort of like screening tests to determine whether somebody may be at risk for Parkinson's disease or better understand the effect of medications on the synuclein by just looking at a peripheral tissue rather than even a brain scan or other measures. So I think it's really promising. The S4 study involves 60 individuals with Parkinson's disease and 20 healthy controls. It was launched really just in the last couple months, and already we've had, I think, almost 20 people that have consented for the study. And this would involve, again, in a single individual obtaining multiple body fluids, meaning saliva, blood, spinal fluid, as well as biopsies from skin, colon, and a salivary gland. So really, in these folks, just characterizing the synuclein burden across the peripheral tissues and fluids is really the key piece of the study.
Would the goal then be, Samantha Hutton, that as you develop this, you could develop a kind of matrix, a kind of key where you could say, okay, you have an alpha-synuclein score of X in your saliva and Y in your blood and Z in your, tissue in after your colonoscopy. And we know enough now to say that with that particular score, that's a way of diagnosing Parkinson's disease. I know I'm describing this in kind of an imaginary way, but is that the overall goal in essence?
That's exactly right, Dave, and I think it's important to note that the presence of alpha-synuclein in some of these tissues may be different early on in the disease as opposed to at later stages, so that could tell us something. But also some of these fluids and tissues are easier to collect than others, so sometimes a spinal tap can be considered somewhat invasive, but taking blood is easier. Likewise, maybe a skin biopsy is something that's a lower lift and easier to do in a population than some of the other tests. So I think it's nice to have options, especially since a large portion of the population, for example, does undergo routine colon biopsy for cancer screening. So if we could sort of piggyback on some of the other types of tests that are already ongoing and sort of put the patients through less poking and prodding, there may be opportunities to sort of look in different tissues that may be easier to access or could tell us more information sooner.
Let's take up one more thing, and then we're going to get to all of your questions, a lot of questions coming in about BET scans in particular, and we're going to get to those in just a couple minutes, but we want to make one last stop on our way before we get to questions, and that's this idea of developing a kind of risk model that might be able to be either diagnostic or even predictive of who might develop Parkinson's disease. Samantha Hutton, tell us a little bit more about this where you do a kind of a combination of factors from genetics to a variety of other things that you can see on this list of 5 different functions here. And this would be a kind of another way of developing a kind of, when we're uncertain about someone or someone who has a family history and they're worried about whether or not they're on course for someday being diagnosed with Parkinson's, this would be a kind of risk assessment tool, is that right?
Exactly, Dave. So researchers have used the data from our Parkinson's Progression Markers Initiative to develop this risk model that has allowed them to differentiate people with Parkinson's from healthy volunteers just based on the 5 criteria that are listed here. So those criteria are their genetic risk factors, their age, their sex, family history of neurological disease, as well as sense of smell. So these pieces of information are relatively easy to access, non-invasive, and readily available through routine tests at your doctor's office or medical records, and they're certainly less time-consuming and expensive than some of the imaging scans. So these researchers, after refining this model with the data from our PPMI study, were actually able to use just these 5 particular criteria in other studies to validate their findings, and their model held up. So I think this is really exciting to be able to apply these criteria potentially to people who are at risk for developing PD, and then using this as sort of a metric to help determine who may be able, who would then go on to develop the disease later and potentially target at-risk people in clinical trials earlier.
And Dr. Jennings, does that mean that this could become something that would be an actual tool that you would have as a clinician, that if someone came in or even someone who didn't yet have any signs of Parkinson's but was worried about it because of a family history, that you'd have almost like a questionnaire that they could fill out, and with that data and some other information would be able to give a kind of predictive assessment? Is that how this could be used?
Yeah, I think that's a pretty good suggestion for how to use this. I mean, certainly we see a lot of people that come in and have a family history, or are worried about Parkinson's for one reason or another, and we really don't have a way in which to sort of predict their risk at this point in time. So I think it would be quite helpful to have a model like this to be able to utilize in the clinic itself. I mean, I think also it has the advantage of being able to figure out who should go on to the next level of testing. So, we've talked about more invasive type testing, including, the DAT scan. Who should be recommended to undergo some of this additional testing. And this may help us in terms of trying to figure out, which individuals would be best suited to move forward with that more invasive testing.
Okay, let's move on to all of your questions, and we're getting lots of questions first about the DAT scan. So let's see if we can clarify some of those first. Mark asked the question, does a DAT scan show the progression of the disease by the size of the dopamine area in the substantia nigra? So I'm going to jump us back to that picture we saw earlier, and Dr. Jennings asked you to respond to Mark's question. So does it show the progression of the disease? And also, what are we looking at? Are we looking at the substantia nigra, or are we looking elsewhere in the brain when we see this scan?
So what we're looking at here in the scan is actually the basal ganglia. So that's where the cells of the substantia nigra actually project into the basal ganglia. So we're looking at both the caudate and the putamen. And the putamen is that lower part of the oblong that actually tends to get lost in individuals with Parkinson's disease, whereas the caudate is the round centers that you can see there. I mean, this is sort of basic, but that's basically what you're seeing. In terms of measuring progression, we usually don't measure progression by looking at the pictures, and we always show pictures in a setting like this where we're having a discussion and trying to help everyone understand how the utility of DAT scan. But in fact, when we're using this for a research measure, we actually measure the number of counts in those regions, and that's really what determines the progression or the rate of progression in a clinical trial. So that's not really done clinically. Clinically, it is a visual read just by looking at a picture, but in a research setting where the level of progression is actually monitored pretty carefully, we have quantitative methods to measure the counts in those regions.
Susan asked whether or not DAT scans show dopamine loss on only one side. So often in Parkinson's it initially presents with problems on one side of the body. Does that read out in the scans in terms of what we're looking at here?
So I wouldn't say, this scan, you couldn't say that it's drastically asymmetrical, but you can look at that Parkinson's picture and see that on the right-hand side, it does seem to be a little bit more loss than on the left side. So, I mean, it is pretty common that the lowest amount of dopamine-producing cells, so the less uptake on that scan, is associated with more intense symptoms on the side opposite of that. Of course, in the brain, the right side affects the left side, especially when it comes to the level of the basal ganglia.
And one more DAT scan question, then we'll get to some other topics. And this is the old insurance question, Dr. Jennings. Do insurance companies pay for DAT scans, or is that not something that's covered?
So it's kind of a fluid situation at the moment. I mean, I think there are some areas in which I don't know if it's standard insurance, but certainly some systems are paying for DAT scan. I would say that's not consistent, and I know that they're working very hard to try to get Medicare and others in line to pay for this, but it's been, I would say, a challenge. One thing that I think will really drive this is if there is a medication to actually slow, that's been proven or has some promise in slowing the progression of Parkinson's disease, especially in the earlier stages, then it's going to be more and more essential for people to get an early diagnosis, and that will really push these insurance groups to cover this.
Great. All right, let's get on to some of the rest of the questions on other things. Samantha Hutton, a question about on the genetic risk score that we were just talking about in that model. The question is, where does that genetic risk score come from? Does that come from, I imagine this person is wondering about whether or not your genetic risk comes from whether or not you've tested through a genetic test for a particular mutation that puts you at risk for Parkinson's. Does that come from family history? How is that genetic risk determined?
Yes, that's right, Dave. It's actually determined through testing the blood samples through a genetic panel. So there are tests that you can do to see different mutations that may be present, and once you sort of look through those, there's a way to calculate your risk factor based on which mutations and how prevalent they are and how many copies. So that's determined by a blood test. That's a sort of a genetic test that can be done.
And again, there are some genetic mutations that kind of increase your odds for Parkinson's. There are a very few that actually are determinative in terms of whether you'll get Parkinson's. But there's a pretty wide range, right, Samantha Hutton? It's not like if you have a mutation, that means you necessarily, in most instances, will get Parkinson's. Is that right?
That's exactly right, Dave, and I think that's why it's so difficult, because we don't necessarily know, even if you do definitely have a mutation, whether you will go on to develop Parkinson's, and likewise, many people with idiopathic Parkinson's disease just don't have any mutations and they go on to develop the disease anyway, so there's certainly a role for environmental factors and genetic factors that just aren't so clear.
Dr. Jennings, a question about alpha-synuclein. Annette writes in, people without Parkinson's also have alpha-synuclein in their tissues, right? So how do you differentiate that in Parkinson's disease? It's a great point, because alpha-synuclein is something everyone has, not just people with Parkinson's. So what is it that goes on in Parkinson's that would allow a differentiation in alpha-synuclein to occur that would lead us to a diagnosis?
Right, so that's absolutely correct. Everybody has alpha-synuclein, but it is a specific form of alpha-synuclein that it seems to cause trouble. In the peripheral tissues, the form of alpha-synuclein that's been identified with Parkinson's disease is phosphorylated alpha-synuclein. So it's a form of the protein which has been metabolized and is not broken down. And ultimately gets deposited within the tissue, in the nerve tissue, whether it be centrally or peripherally. So that's the main difference, is that there is a sort of an aberrant form of synuclein, which is called phosphorylated alpha-synuclein, and that's the pathological form of it.
Question about another DAT scan question about what it's like to get a DAT scan. Bill Bucklew, did you have one done? Do you have anything you can contribute to that question?
Yeah, sure. I joined the PPMI study, so as part of that study, I've had the DAT scan and went through the process. And it was pretty interesting, and just along the lines of everything said here, definitely would have been great to have something like that earlier in the process for me. but yes, I did have it, and it went well.
And it wasn't unusually arduous, from a patient point of view to have the scan done?
No, it was on the verge of taking a nap during the during the process. So if that's an endorsement, I guess no, it wasn't
right
at all.
Bill references the PPMI study, and I always get these initials goofed up. I'm going to give it my best, though. It's the Parkinson's Progression Markers Initiative. I hope that's right. I should know at this point in my life.
Perfect.
But this is a long-running study to try to figure out a biomarker, an early way of determining Parkinson's disease, and also be able to measure its progression. Bill, thank you, by the way, for participating in that study. It's such an important thing that people can do to participate in research. A question about gut bacteria and whether or not that is useful. Dana Jennings answered the question about gut bacteria, but also, if you would please note, and Samantha Hutton talked about this earlier too, the gut's interesting because alpha-synuclein clumping does show up in the gut, and that may be why so many people with Parkinson's have constipation problems. Again, perhaps an early warning sign. But what can the gut, I guess, tell us about Parkinson's disease?
Right. So getting back to the synuclein point, and this is really why in S4 we're targeting the colon as one of the tissues that we're biopsying as part of this study. It does appear that, and this is based mostly on pathological studies, but also some studies in individuals with Parkinson's disease, there does appear to be an increase in synuclein in the nerve fibers of the gut. And we definitely know that the nerve fibers of the gut are affected in Parkinson's disease, which is presented oftentimes with constipation. So it all sort of makes sense. And it, again, to the point of, could this actually be an early marker of disease? Oftentimes, and there's studies to really show this, that constipation is a symptom that occurs long before individuals develop any other motor sign of Parkinson's. So it may be that synuclein, or phosphosynuclein, I should say, is present in the gut pathology, very early on. How does the bacteria relate to this? I think bacteria in the gut probably doesn't have much of a relationship to Parkinson's disease. That's just I don't want to say this, but my gut feeling. At any rate, I think it's really more related to the synuclein. But go ahead, Samantha.
That's true, Dana, but we've actually funded some studies that seem to indicate that there are certain types of bacteria actually in the gut that are present at lower levels in people with Parkinson's disease compared with healthy volunteers. So I think there's an interesting correlation there, especially given the constipation issue that's so prevalent in Parkinson's disease that you mentioned, and the fact that the colon and the gut is sort of the peripheral brain, if you will. The cells in the colon and the gut are very similar to brain cells. So I think there are some connections there, but we're still sort of figuring them out.
Interesting. Okay, thank you. Another question that's coming up is about people with REM sleep disorder behavior. Again, that's acting out of dreams, and along with loss of sense of smell and constipation, seems to be something that sometimes is a kind of early warning signal of Parkinson's disease. Bill Buckley, let me ask you about that. Have you had any of that sleep disorder problem, and did any of that occur early on for you?
I don't think it really occurred as early as the other symptoms, but I do have sleep disruption, and it can be pretty significant in that, if I do actually wake up in the middle of the night, I really can't even get back to sleep. But that's more recent in the last 2 to 3 years than really early on for me.
Right, and sleep issues are an enormous problem in Parkinson's. We're actually going to take that up on a later webinar. The acting out of dreams part, though, Dr. Jennings, how are we any closer, I guess, to being more precise about these early indicators? Because obviously, acting out of dreams, constipation, loss of sense of smell, while they can be connected to Parkinson's, they can be connected to other things too. So is there any way, I guess, of getting more definitive about what those early markers might really indicate when it comes to Parkinson's?
Yeah, no, they're important markers, and as you point out, there's a lot of people that actually have these symptoms that actually may not be at risk for Parkinson's and never go on to develop Parkinson's disease. So we need a better way of increasing the specificity of those tests. I mean, they're pretty sensitive tests for Parkinson's disease, but not everybody that has those symptoms clearly goes on to develop Parkinson's. I will say, though, that REM behavior disorder is one of those symptoms that actually is pretty specific to Parkinson's. A lot of people,
okay.
A high percentage of people do go on to develop Parkinson's that have REM behavior disorder, acting out of dreams. That's not so true with constipation and a decrease in smell identification, really, or decrease in olfaction. So those tests really need to be combined. I mean, they're common enough symptoms, clearly, and really need to be combined with other risk factors, which is really to Samantha's point a couple minutes ago, where this risk assessment involving lots of different pieces and providing a risk score, I think is probably a key piece. But, I will say one last thing about what Bill commented on about the sleep, and he really didn't comment on the sense of smell, but almost everybody with Parkinson's disease, by the time they get a diagnosis, has a decrease in their sense of smell, and it's pretty severe. The loss of smell is actually quite affected by the time a diagnosis occurs. But in research studies, it's shown that about 35% of people that have that loss of the sense of smell don't even recognize it. It's not a sense that we might be so aware of. So having a test for that is really critical versus just asking the question, do you think you have a decrease in your sense of smell? People are not so aware of it.
Yeah. One last question, then we'll get a couple of closing comments as we approach the end of our hour. Good question from Daniel, who asked, if a patient has some of the genetic precursors and also shows some of the early warning signs of Parkinson's, would it be plausible to start that individual on a prophylactic dose of dopamine as a treatment? Dr. Jennings, on that point, we wish that there were, right, a disease-modifying treatment that we could start people on early on. We're not there yet, and that's not actually what dopamine replacement drugs do. But that's the dream, right, to be able to identify this early on and then sort of stop the disease before it ever really gets started.
Right. So the hope is that we can, first of all, identify people in the very earliest stages before motor symptoms begin, and then identify medications that would prevent the onset of the motor syndrome of Parkinson's disease. Of course, the non-motor symptoms can be disabling also, but to either slow it down or prevent the onset is certainly the goal here.
And Dave, we did talk about synuclein as that protein that clumps in the brain, and I just do want to end on a high note by saying that there are at least 4 drugs directly targeting that protein in the clinic right now. So I think the time is ripe for disease-modifying therapies, and with the development and the continued efforts around biomarkers, which could potentially help to track whether those drug treatments are working, I think we're at a really exciting crossroads, and just wanted to end on a high note by highlighting that fact, because I think we're really excited about all of that at the foundation, and in general.
No, thanks for adding that, Samantha. And just to underline the point, when Samantha Hutton talks about being in the clinic, this means that these are in clinical trial. So we're testing those right now in clinical trials, and we hope in the next few years we'll have an answer as to whether or not some of those treatments might actually slow down the clumping that takes place in alpha-synuclein. Just 2 quick points before we close, and Bill, I'm going to ask you for a closing thought. If you, on the slide here, you see that, again, that you can download our resource list. We encourage you to do that. There are also references to past webinars where we take up in more detail questions like alpha-synuclein as well as other aspects of living with Parkinson's from sleep to exercise. So do think about adding those. And as we conclude this webinar, we also want to encourage you to consider participating in clinical research. And Bill, I'm going to ask you to make the pitch on that, actually, as someone who has participated in PPI and other research efforts. If you would just close us out by commenting on the importance of that for everyone in the Parkinson's community.
Yeah, no, absolutely. I mean, so as I mentioned, I kind of jumped right in and joined the PPMI study, which I felt was important to get involved at that level. And then I also have been involved in doing fundraising for research as well through various organizations. And, I would just say that for me, getting involved early on, and, everybody has to find the right level of involvement for themselves, but it really helped me deal with the diagnosis and the implications as being part of the progression towards finding answers to a lot of the unknown questions. It allowed me to really cope with things better and feel like I'm part of the engine driving forward to eventually finding a cure, which just emotionally and everything else was really helpful for me. So, my pitch would be to find the right level of involvement for yourself and whatever that means, and then, to go for it.
Bill, thank you. Thanks for your participation today and also for your participation in these research efforts, which hopefully will get us to where we all want to go. Thanks very much for participating today. Thanks, too, to Dr. Dana Jennings and to Dr. Samantha Hutton for their contributions to our conversation. We really appreciate it. We'll be sending a link to the webinar on demand so that you can listen again or share with others. We'll also send a survey link in that email so you can help us assess and evaluate today's presentation. We also want to ask you to mark your calendar for our next Third Thursday webinar, which will be on Thursday, April the 21st, where we're going to talk more about kind of the personalized medicine approach to Parkinson's and how treatments may be prescribed based on the kind of Parkinson's that you happen to have. We're learning so much more about the differentiation in the Parkinson's experience, and we're going to talk more about that personalized issue in our next Third Thursday webinar. And last, again, you can visit our Facebook page, Fox Foundation Facebook page, on Monday at 12 noon Eastern, where we'll answer your remaining questions on diagnosis. Thanks, everyone, for participating today. I'm Dave Iverson.